Welcome to this section dedicated to the extensor apparatus. We will start with a few key anatomical reminders about the extensor system. Here is the dorsal side of the hand, showing the bony structures, followed by the extensor tendons that run superficially over them. The extensor apparatus is a complex system of anchoring and stabilizing structures arranged in a series along the extensor tendons, which we will examine in detail one by one. First, there is the retinaculum of the fourth and fifth extensor compartments at the wrist, corresponding to the common extensor tendon of the fingers and the extensor tendon specific to the fifth finger, respectively. Second, proximal to the metacarpangulal joints, intertendinous connections known as the juncturae tendinum, linked to the extensor tendons on the dorsal side of the hand at the distal ends of the metacarpals. Further, distally, at the level of the metacarpophalangeal joints, are the sagittal bands, which stabilize the extensor tendons. These bands function like true guy wires, anchoring to the planar plate on the palmar side of the fingers and converging on the dorsal side to form an arc around the extensor tendon. The extensor hood, formed by the aponeurotic expansions of the interosseous and lumbrical muscles, consist of fibrous layers that insert onto the central slip, followed by the lateral slips, which can be considered extensions of the sagittal bands. It is clear that these structures facilitate the connection between the flexor and extensor systems. Finally, at the distal end, there is a sophisticated system of slips, with a central slip inserting onto the base of the second phalanx P2 and two lateral slips that encircle the proximal interphalangeal joint, merging into a terminal slip at the base of the third phalanx P3. To perform a thorough ultrasound examination of the extensor apparatus, it is essential to start at the wrist and locate the extensor tendons at this level. Two ultrasound landmarks are particularly useful for this. First, the dorsal tubercle of radius, which is always parabole and located just ulnar to the long extensor tendon of the thumb, followed by the common extensor tendons of the fingers. At the level of the distal radio-ulnar joint, the extensor tendon specific to the fifth finger becomes visible. The extensor reticulum, surrounding the common extensor tendons, appears as a bulge around these tendons. Continuing distally, it is important to note that the third and fourth fingers generally have a single extensor tendon, which appears on ultrasound as a hypoechoic, anisotropic, elongated, oval band that progressively thickens as it approaches the metacarpophalangeal joint. Here, we observe a single extensor tendon on the third ray, in contrast to the second and fifth rays, which each have two tendinous structures. As shown here, on a double tendinous structure, the more radial structure corresponds to the tendinous portion from the common extensor of the fingers, while the more ulnar structure corresponds to the extensor tendon specific to the index finger. These structures can be differentiated at the level of the head of the second metacarpal. For the fifth metacarpal, we begin again at the distal radio-ulnar joint. Typically, this tendinous structure divides into two layers, which can be clearly visualized as they move towards the head of the fifth metacarpal. It is important to note that there is some variability in the anatomy of these tendinous structures. Here is a schematic representation of the most commonly encountered variants. This point is crucial, as understanding it determines the feasibility of potential tendon transfers. The second element of the stabilizing the extensor apparatus consists of the intertendinous connections, known as the juncturae tendinum, which appear as small hypoechoic and anisotropic bands running from one extensor tendon to another. Intertendinous connections may be affected by traumatic pathologies, ruptures, tears, or traumatic sections, which can manifest as a hypoechoic thickening of a stretched linear structure between extensor tendons. We continue our examination by following the extensor tendon at the level of the metacarpophalangeal joint as shown here. Positioning over the metacarpal head, we observe the sagittal bands, which appear as thin hypoechoic lines inserting on the palmar side of the finger and wrapping around the extensor tendon, both above and below, to form an arch. It is essential to test the continuity of the extensor tendons by performing a dynamic maneuver, during which the patient's hand is advanced so that the finger extends beyond the edge of the examination table. At the level of the metacarpal head, dynamic flexion and extension movements of the fingers are performed. During this maneuver, the extensor tendon remains perfectly centered relative to the metacarpal head and is anchored against the cortical surface of the third metacarpal, as observed here during flexion movements. Traumatic injury to the sagittal bands is often characterized by the condition known as boxer's knuckle, which typically involves a rupture of the radial sagittal band, resulting in visible discontinuity as shown here. This condition may present with a perfectly stable extensor tendon during dynamic movers, indicating no instability, or it may be associated with instability, which can manifest as either subluxation, as seen in this example, or a complete dislocation of the tendon into the intermetacarpal valley. For the fifth ray, we previously observed the arrangement of two extensor tendons, typically originating from the dedicated extensor of the fifth digit, usually accompanied by a small hypoechoic intertendinous band between these tendons. To test this band, a dynamic maneuver is again necessary. The patient's hand is advanced, with fingers extended beyond the table, while flexion-extension maneuvers are performed, usually accompanied by a small hypoechoic intertendinous band between these tendons. To test this band, a dynamic maneuver is again necessary. The patient's hand is advanced, with fingers extended beyond the table, while flexion-extension maneuvers are performed. This maneuver demonstrates the perfect stability of these tendinous structures, with no radial or ulnar dislocation relative to the metacarpal head. In the case of the fifth ray injury, the intertendinous band may rupture, potentially causing, as shown here, dislocation of the extensor tendons on either side of the fifth metacarpal head. This finding clearly indicates tendon instability. Now let us turn to the central slip and lateral slips. Starting from the previous position at the metapaphalangeal joint, we observe the central extensor tendon aligned to the proximal flanks. Then, as seen here at a variable point of division, the central slip appears in the middle, flanked by the lateral slips on either side, creating a trifurcation. You can see a fine hypoechoic slip here corresponding to the central slip, which inserts at the base of the second phalanx, P2. This analysis is easier in the sagittal plane, so it is recommended to use an ultrasound gel tube to facilitate dynamic maneuvers if needed. Position the probe in the sagittal plane to identify the superficial tendinous structure, which corresponds to the central slip. Note that it inserts onto a flat surface at the base of the second phalanx, P2, and fans out into a broader structure at this insertion point. Dynamic maneuvers allow for the identification of movement in the central slip. Here is an example of a central slip rupture, slightly proximal to the distal insertion. Dynamic maneuvers aid in diagnosis by revealing a lack of tendon mobility. We can also observe the initial dislocation of the lateral slips, which, if left untreated, could lead to a boutonniere deformity. It is important to emphasize that the analysis of the central slip should not be conducted in isolation. It must also be paired with an examination of the palmar plate and collateral ligaments. Now we turn our attention to the final structure, the terminal slip of the extensor apparatus. Starting from the proximal interphalangeal joint, We observe here the central slip and the lateral slips, which wrap around the proximal interphalangeal joint, remaining primarily on the dorsal side. Here is the lateral slip on the radial side, and here on the ulnar side. These slips converge distally to form the terminal slip, which inserts at the base of the third phalanx, P3. Similarly, the terminal slip is easier to analyse in the sagittal view, where it appears as a much finer structure. Similarly, it strengthens as it inserts onto a flat surface at the base of the third phalanx, P3. Dynamic manoeuvres, such as this, can be performed to test its continuity. Here is an example of the chronic rupture of the terminal. Ultrasound reveals a distal detachment at the base of the third phalanx, P3, with a gap in continuity and retraction of the tendon stump. Dynamic manoeuvres demonstrate a lack of movement during flexion-extension of the distal interphalangeal joint. Note that there is no avulsion of the bone in this case. This concludes the study of the extensor apparatus.